First part of the presentation will be Gareth talking about gastroenterology in a time of COVID, followed by Asma, who will take us through some functional gut disorders, and then Sean, who will talk around endoscopy and access to tests and green and other blue type issues for the hospital end. So as we mentioned before, please put any questions in the chat area so that we can pick them up as we go along. We'll also be able to have questions at the end, but as it's now 6:30, Gareth, if you'd like to introduce yourself and kick us off.
Thank you very much, Phil, and to Tower Hamlets GPs in general for inviting us to come and talk. It's a real pleasure. So my name is Gareth Parks. I'm the clinical lead for gastroenterology. I've got a sub-interest in inflammatory bowel disease. So I'm going to talk a little bit about the background. I was going to do a complicated thing and then flick between myself and my other speakers and talk at the end, but I think it'll be easier if I just talk all the way through this. And I have just lost all my slides. So how did that happen? They've all just gone. I think it was Jens and Emma have come in, and I can now see you, and I can't see my slides. So this is going to be very difficult. I can talk about the two of you. Come on. Where's the window? Where's he gone?
Okay.
I've done mine in a complicated way. Are you seeing my screen now?
I think we are, yes. So I think you just need to click on the PowerPoint and then just play.
Okay, fine. So hopefully you can see the screen now with the slides. So just taking us quickly back to March, because we're a bit different from many of the specialities you've probably heard of. We're, although at the Royal London we try and pretend that we're all gastroenterologists, we're all accredited in general medicine as well. So when March came around, we were about 24 consultants in gastroenterology and hepatology. We've got 8 registrars of either training grade or above ST3, some clinical fellows and research fellows. And when the pandemic hit, the majority of those all of those people were based down in Whitechapel, either in academia, and our colleagues in other sites were definitely less well staffed. And as the pandemic hit, both Newham and Whips, as you're probably very aware, had a real staffing crisis very quickly. So the Medicines Board moved and we lost our consultant body and we ran down to this. So we had 7 of us running 2 wards now. Normally we'd only run 1. We had 4 of our team went to run an independent ward, an MAU at Whips Cross, including people like Graham Foster, an academic professor. He's 100% paid by the university. He was running an MAU. And 4 of the team went over to Newham. Sean, although he doesn't like to talk about it, went to basically set up endoscopy at the Nightingale, which at the time we thought might have thousands of patients, and managed to coordinate a rota across all of London. Like most people, we had some consultants who needed shielding, including colleagues who were over 70, and so we kept some people back behind, and they all ran services. Plus, we kept another consultant who basically almost single-handedly for a while ran an IBD service of 3,000 to 4,000 patients. So that's what happened to us when the pandemic hit. And our registrars, again, were amazing. So 8 in research, 3 sort of teaching fellows or above, and all of those then went and joined the rotas, both at the Royal London and elsewhere. But I really want to point out how amazing primary care has also been during this pandemic, because it absolutely hasn't been about us alone. So this is data from a recent dashboard that we've produced, and Roberta may have seen, because it's part of how we understand what's going on. And you can see that GP referrals here in light blue basically have tanked. It is not clear to me yet but what the other referrals are, but there's that activity. And I thought I'd highlight in particular how amazing the Aberfeldy practice has been, given our hosts. And you can see here that basically here they go along quite normally, and suddenly it absolutely disappears. And part of that is that some services have been switched off. So part of that is as we shut the gate. But I want to really highlight and say thank you to the fact that primary care has held back a huge number of patients, and to some extent patients have held back and we're all aware of that as well. So I think we should talk about what that means to our outpatients. So I'll go on to it, but inflammatory bowel disease, we just did not know how to manage the risk of that, of trying to switch it off. So we kept to some degree a continuous outpatient service for those people who weren't on the wards throughout the pandemic, and that has been almost uninterrupted, as has our 2-week wait ability. So essentially, we used consultants who were over the age of 65, who we were trying to keep out of the coalface or of the front line, and if I could spell continuous, but that has been open the whole way through, although endoscopy shut down almost to the point of nothing going on. Our general gastroenterology, we had 2 to 3 weeks of hard switch off. We tried to manage this, just so you're aware, that we didn't just blanket shut clinics. Every patient that we cancelled, we triaged, and we thought that they could either be discharged with a letter. Maybe we had all the results and they were a follow-up, and we actually sort of did a virtual review and say, look, your colonoscopy is fine. I've looked at your histology. This is a polyp. You'll need a follow-up in 5 years' time. And so we were able to discharge those. We could defer some patients and say, look, we'll see you after the pandemic. And we're now seeing those patients. Or again, this is that sort of virtual review. There were some patients in whom we said, look, pre-pandemic, we absolutely would have seen this patient. They're a new patient coming up. But on this occasion, we just think that not only can we not see them now, but actually they wanted to come up for a second opinion or third opinion from somewhere else about their irritable bowel syndrome. Actually, this is just not the right time. They're going to have to just be discharged. So some patients were discharged, but nearly always with letters of management. And by mid-April, clinics switched back on, nearly all of that. And then telephone has been our default setting all the way through. So we've seen almost no patients, down to a handful face-to-face, just as the same way as primary care. And by May, all our clinics are full. We're running all of them without cancelling anything, including all our SBR clinics, despite not having any SBRs at all. So we are managing our SBR clinics as well, just because we feel that pushing the problem further down the line is just not tenable. STT is the probably caveat, where what we discovered, STT is a horrific, complicated mess that will be sorted out in 2020, or I put my kind of reputation on the line. And essentially, we discovered that central appointments had switched off the direct booking system that allowed you could refer in. I even got my wife to do a dummy run, and it looks open at your end, but we discovered that there were about 80 patients in whom had been referred but were not being matched to appointments. It's now completely back on, and we're trying to work our way through that. Okay, so that's the sort of general picture of where we are probably now in June. I want to focus a bit on inflammatory bowel disease. I'm sorry, the way I've got this, I can't see chat. So Phil.
Okay, so Gareth, just for those who aren't acronym-istic, STT, straight.
Sorry, that's straight. We call it straight to triage, but essentially is in fact, that's what it says on the top of your form. When you upload it, that's you want either a direct access gastroscopy, colonoscopy, flexible sigmoidoscopy, or you'd like the patient to and then be seen in clinic afterwards. That's your general referral to us. Okay, and the issue was in May? So the issue was in March, that what happened was all direct booking so most of our clinics run on RAS. This is now very nerdy terminology for outpatients, the refer and advice system. But rather than DBS, which is much more like choose and book, where you, the GP, books a slot into a slot. Now, STT runs on that DBS system, where you actually book not into a real outpatient appointment, but into a virtual outpatient appointment that happens in the middle of the night. And what we hadn't realized was that had been switched off by central appointments. That got switched off in whenever it was, late March. And we discovered in early May that had been switched off. But by definition, that is our routine way into our service, not our 2-week waits. And as Sean's going to explain to you, essentially that the ability for us at that point to do any endoscopy, routine endoscopy, was almost zero. We were doing emergency work only. So we don't feel that there was a huge problem, but there was a miscommunication between central appointments and ourselves. Our service manager did not know that was going on.
Okay, and going forward, the STT forms that we would normally use, are you going to cover that a little later, or is that?
So I'm probably I can do. Essentially, the service is open. We just ask you, and I think we'll wait until you've heard Sean's talk about what you have to do in order to get an endoscopy at the moment. I think really changes your thought pattern on whether it's a good idea or not. It is Sean will tell you, it's an aerosol generating procedure. So this is a big issue. And our endoscopy unit sits on the same floor as our now green surgical floor. So where you would hope to be able to safely have, mum's hysterectomy for uterine cancer is going to be on the same floor. So they are trying to keep that as green as possible. So, and by green, we mean we know that a patient has a lower probable chance of having coronavirus carriage as either symptomatic or asymptomatic as they walk into the building. So to try and reach that goal is very difficult. And as such, we are trying to use alternative ways. So, but why don't we do that when Sean talks?
Okay, so that's very clear. So there's a question coming through on the chat from Jaya. One of the issues we've had in primary care, for example, with colleagues in radiology with ultrasounds, is that a lot of them have been bounced. They were all bounced back, just saying, we can't do them.
We have not.
That's now been rectified. But with these I think the question is, with these STTs that maybe were sent in March and April that were discovered in May, do we need to do anything about them, or have you got that under control?
We are owning the risk for that. So essentially, if they are discharged, we will let you know. But essentially, we have owned the risk, and we said that we have individually triaged patients on there. Some of which we've said, look, on balance, we don't think this is necessary. So, and maybe we should have never said yes in the first place. But the time in which we've got to triage referrals is pretty limited. So, and all of us probably had a different, just in the same way as I'm sure general practice has a different prism through which it sees life now post-pandemic. And so there's a little bit of that. A lot we've deferred. We've kept, for example, all our surveillance patients. It's a big problem. It's a big risk. But the first patients sort of through the door and that we're trying to continue are those patients in whom we really worry that they might have cancer. So it's really cancer.
I think that's answered the question. So we don't need to do anything about it. You'll look at all those people that were discovered and sort them out. I hope that answers your question, Jay. Okay, IBS, let's go for it.
IBS, honest to goodness, this is IBD.
Oh, sorry.
Really upsetting me. So just a quick bit of background. We're 3,000 to 4,000 patients that span all the way from tiny infants through to the 93-year-olds across the whole of southeast of England. We've got a big team, as you can see there. It's really multidisciplinary, and we're really proud of that. And we get on hugely well with the team, all the way through to access to a psychiatrist, Peter Byrne, who some of you may know, and a psychologist, which is incredible. And we run our own in-house infusion service rather than using a generic infusion service for our biologic patients. Redesigning this has been hugely difficult, and we just wanted I want to use this opportunity just in case you've got patients with coronavirus, with inflammatory bowel disease, and they talk to you about risks. What is the risk of coronavirus for IBD patients? How are we going to safely look after them? That's our role, and together. And where can our patients safely come for infusions? And I can show you a bit about that. So the first thing is, what's the risk for coronavirus? Well, I really suggest if you have got patients who are coming to you to talk about shielding, the first thing to do is absolutely point them in the direction of our helpline. In the final version of this slide, I'll make sure that's in there, but it's 0203 594 3700. This is set up by the national charity Crohn's and Colitis, and it is a patient. The patients go through this risk thing themselves, and can because I'm sure all of you and we the same. The vast majority of all the traffic through to our helpline has been around this. I'm not going to dwell on it a huge amount, mostly because the government, as we all know, are announcing the sort of end of shielding in about a month's time. But we are still very aware that there are going to be patients who are definitely at higher risk were they to get coronavirus. We have begun to get a bit of data on what would happen if you had inflammatory bowel disease. There was an amazing database set up for free internationally including teams from China and Italy in the very early stages. And we've got the first sort of cut of data has come through on this. Anyone can upload a patient with Crohn's or colitis who was swabbed positive for coronavirus. And as we get antibody tests, we're going to see a large amount more. And then you put in all of their kind of medication they're on, age and comorbidities, and they've had a crunch. Now this, to put it in context, there are about 2,000 patients on this now, and this is a cut at 500, which is where they decided to publish. You can see, if my mouse shows up, that this age doesn't look like much, but it's highly significant. This is for every additional year of your life, there is a significant, and that no one needs to be told that. No one needs to be told that if you're a man, as I know, you can go down like a, we're not all as strong as Phil, you can go down like a sack of cards. But strangely protective for Crohn's, although not significant. So let's forget about those. So corticosteroids, if you're on corticosteroids, a significant increased risk across the board of a bad outcome. So we don't like steroids and we try really hard to avoid them, but sometimes they are. And this goes against the whole dexamethasone story, but it's interesting. With the dexamethasone story, if you did not require oxygen, you actually did worse if you're in the dexamethasone arm. It was only once you got to the oxygen requiring and worse that there were bad outcomes. So it's about timing. And what we see here is that if you were a patient on steroids at the time that you got it, you had a worse outcome. Anti-TNFs, no signal for concern there. Smoking, bizarrely, no signal for concern there. BMI, as you might expect, it's not significant, but it was never powered to look for that, and we don't need it for those data. Slightly concerning is a signal around 5-ASAs. Now, essentially, I've had a chat on a national call. You know, 5-ASAs are the mainstay of our treatment for UC, and very mild and very safe. We didn't think there was any concern. We put them in the low risk category. But what we think is happening there is these are preferentially often used in older patients. We think that even though this has got multivariate analysis, we think that if you were on an anti-TNF, you were very likely to get a test. So lots of these anti-TNF patients were coming up to hospital on a routine basis, and lots of centers were doing tests on them anyway, just to let them into the building. And so we think that played a role, that we are skewed for the fact there were far more patients on anti-TNFs and immunomodulators than we would normally expect. And these 5-ASA patients just happened to be, the only time they got a test is when they were very sick. So that we weren't going out to all patients and saying, have you got coronavirus, and therefore finding the asymptomatic ones. So that's where we think, and we think that we're not changing our signal at the moment. So service redesign, just very quickly, who, where, and how. So our team really shrank down to almost no one. So one, Prof. Rampton was doing all his clinics from a kitchen table. He was in isolation and running our helpline from his kitchen table as well. And now, thankfully, we're almost back to a full complement of our team. The where was a big issue. So obviously, well, not obviously, but our infusion unit was right next door to our endoscopy, which at the time was taking patients with coronavirus in order to scope them. So that wasn't ideal. So we first moved to the Dental Institute and then on to Mile End in order to protect our patients. Some patients are obviously working at home. Some clinics are working at home. The infusions are all happening there. Endoscopy, we've looked at private providers, but that, Sean will talk about that. That's sort of falling a little bit by the wayside, and we're trying to get up and running here because it's just much easier. But again, lots of testing, isolation, and surgery, again, was a real problem. I just want to talk about the new diagnosis. We worry a lot about patients who are out there and that there might be blocks to our service. So if you are ever worried about somebody, I honestly don't mind if you just drop me an email if you've got a patient, or you please use advice and guidance. Our efficiency on advice and guidance, again, I had a look at our data. We are about 90% answering in 48 hours. If you've got a patient, use fecal calprotectin. It has revolutionized this, and our CalPro service has run throughout the pandemic. It wasn't switched off, and I can let you know it was switched off in lots of other places in the country because of fears of coronavirus passage in feces, but it's been going, and that's been fantastic. And when we find them, we normally call them first to get some idea of what their symptoms are like, make sure that this isn't just gastroenteritis, and then we can direct them into a scope. So we worry about blocks, patient fears, maybe a GP knowledge gap, rejected endoscopy, us rejecting patients or colleagues, or at some point it was being triaged by our nurses, or patients getting stuck in colorectal pathways with inflammatory bowel disease and not able to access service. Because if they get sick and they require steroids, if we have another peak, then that is something we really worry about. Following up, we've got lots of ideas. I might just talk very briefly about a mobile platform that we've developed, something called MyIBD Care. But essentially everything is telephone at the moment. Because we are the Royal London, we can't use AccuRx because it's too good and works too well. So we decided we definitely back the horse, which is limping along way behind, and we are wedded to NHS Attend Anywhere. We have no choice. That's where it's going to go. It does require a big rebuild in order to change our clinics to video. So the vast majority for us remain telephone. We do have a hot clinic, which we've also set up. And again, that's at Mile End. My watch is buzzing, which means I think there are lots of questions. This might be a time to take them, Phil.
So actually the question's no, your watch is buzzing maybe because you've reached 6:50, I'm not sure, but
it's telling me I should put
there's a big up for the advice and guidance service from Gastro. It was fantastic, thank you. And Emma is suggesting that you can push for AccuRx if you want.
No, you can't, but anyway, because Connor would tell her that we have been verboten. Bart's website mention advice and guidance.
Okay,
it's just said.
So Kenny, you've just put something on there which I can't quite see. Do you want to unmute yourself and ask the question?
I just wanted to say I just went onto the Bart's website, and I think. Hello, can you hear me?
Yeah, we can hear you. Yeah, go for it.
I know. I just wanted to say that I just went to the Bart's website, and it doesn't mention advice and guidance, and it still uses that old Bart's advice and guidance email address. I think is what it says on the Bart's website. So I just wanted to highlight that, and maybe that should be corrected.
Yeah, I mean the website. I'm surprised it still says that we're actually Bart's Health, and it doesn't say that we're the Royal London Hospital. We have no control over that, and I think the comms that have come out, which maybe you can tell us maybe towards the end if those have lacked, but the comms we've asked to put out, I think across the board, is to please use advice and guidance if you do, if you've got any questions, if it's not a super obvious, if it sits in that category, perhaps below cancer, and you really want to make sure they're seen urgently, we 100% can see those patients. And if need be, face to face, we tend to do a screening telephone call, probably in exactly the same way as you do in primary care. But we've had patients in whom they might have a perianal abscess, they may have an abdominal mass, and which nothing will, a hand on the tummy is definitely worthwhile. So that makes a big difference.
Archner is talking about fecal calprotectin. If it's raised very high, does it equate an urgent referral?
Yeah, there's a really good correlation. So if you're talking about a calpro in the thousands, then what it says is that is a very inflamed bowel. Then you've got to ask yourself the question, do you think that's an inflamed bowel that happened because they ate a dodgy Indian the night before? Or is that an inflamed bowel because this patient has had symptoms that have been going on for a few weeks or months, and that is highly likely to be inflammatory bowel disease. There are, severe diverticulitis, a duodenal ulcer, but it is a hard sign of pathology. It can go up and come back down again, but yeah, absolutely, just drop us a line about those.
And the second part of the question is, how far apart do you repeat calprotectin? Is there any guidance on that?
So if it was 1,000 and somebody had been unwell, and for example, they've got I've had a patient who's got a CRP of 16, a calpro of 2,000, a brother with Crohn's disease, I'm not repeating that. That definitely doesn't need repeating. That's if you've got a calprotectin of 150, a slightly funny story, it's all happened quite quickly, then that's the time when you might not do that. Sorry, you might repeat it again. I'm just going to go back to my screen. I'm now showing you here. I'm going to skip through a bit. This is my IBD
app for patients.
Oh, right, sorry. Oh, where is that coming from? That's a pre-recorded bit, so we can ignore, because I did that for the Royal College. I just wanted to say, please contact us via, I was going to put my email address in and then I think I forgot. And I really wanted to end, this was going to be the end of the whole talk on just saying that one of the fantastic things has been a collaboration between us and primary care when it really works. And I wanted to say a massive thank you for your patience, resilience, as I showed you, holding back referrals, for communication when it works and your understanding. And I wanted to highlight this, if it works. This is an example. Now, it's very unfair of me because he did send this to me in good faith. But essentially, Phil has been communicating with a colleague of mine with a patient who's very close to having intestinal failure. In this, it does look like you might need an optician or an optometrist, Phil. But if I can make this work.
Okay, so the deal is that the patient doesn't have any scales at home, so I'm going to have to individually measure out the 26 grams in some sandwich bags. Okay.
So that, for those who don't know, that is St. Mark's solution, which works really well for patients who have got, sorry, Phil, that's really cruel of me, but that's St. Mark's solution, which works incredibly well for patients with an ileostomy who have enormous problems with dehydration and go into kidney failure. And this was an example between this patient had required parenteral nutrition for a long time, was now discharged, but was really struggling. And a communication between us, or my colleague Belle Koch and Phil, has kept that patient out of hospital. But what we don't realize, and I pointed this out to my secondary care colleagues, is that when we say things like, you know, why don't you use some Mark solution, that actually delivering that care on the ground sometimes requires, you know, going above and beyond, as Phil just demonstrated there. And I want to say a massive thank you for that. And with that, I should probably try and relinquish. There you go. Somebody's saying £220 as a special ingredients, or less than £2. I saw fair trade sugar, bit of bicarb, bit of salt. It's cheap as chips. The best thing that anyone ever invented in gastroenterology was oral rehydration solution, and that's very similar. So I'm going to stop sharing my screen, and hopefully that can now allow Asma. Why don't you go first, and then Sean can go.
Thanks a lot, Gareth. That was, apart from the video, that was very instructive. Thank you. Any more questions for Gareth whilst Asma is setting up? So huge thank you. And certainly whenever we've needed to contact you, I think advice and guidance, email, it's always been a quick turnaround. Roberto has put a little comment on about advice and guidance. If you're finding difficulty, I think, with advice and guidance and not getting responses, there is an escalation policy if you don't have a response within 5 days. So do use that. I think we're mostly having now the ability to do that direct from EMIS. Good, and thanks, Roberto, for putting that up. So there's one question that's coming from Chi Ling, Gareth, whilst Asma is looking for the...
I'm give that one to Sean, if that's all right.
Okay. Okay. Sean, do you want to answer that question? Do you need to send off fit tests prior to 2-week wait, lower GI referrals, and only if positive refer? I think we've dealt with this in a few webinars on cancer, and I think Tanya has dealt with it in the past. But it's always good to have it reinforced ready. So Sean, do you want to answer that question before we go on to Asma's talk?
Sure. The very short answer is yes, but I will be covering that as part of my talk after Asma's talk.
Wonderful. Thank you. So we'll deal with that later, Chi-Ling. I think the bottom line is yes, but if it's absolutely obvious, I think there's also a direct line in as well. So, but we'll wait to hear from Sean. Asma, fire away.
Thank you. I hope everyone can see my screen and can hear me as well. Yeah.
Perfectly.
Good. Okay, so I'm Asma Fikri. I'm one of the other consultant gastroenterologists at the Royal London Hospital, and I have a subspecialist interest in neurogastroenterology, which is just a really fancy term for functional GI disorders. So just a bit of background about what I do. I run a tertiary neurogastro clinic where we see really severe patients, so patients with severe functional disorders who come from around the country and sometimes beyond. And often they have a lot of associated comorbidity, drug addiction, eating disorders, etc. But then I do also do a lot of general gastro clinics where functional GI disorders are rife. And I don't need to tell you all this, but we all know that functional GI disorders are really common, and they account for about 12% of your workload in primary care. And 50% of patients who come to you with GI symptoms will end up having a functional GI disorder. And those patients, so 50% of those patients who see you will probably end up being referred to secondary care at some point in their journey. And so in secondary care, about 1/3 to 40% of our workload is accounted for by by patients with functional disorders. And just looking at the e-referrals that we get, or the STT referrals that we get, again, about half of them are accounted for by functional disorders. So these disorders are really common, but they're also associated with huge healthcare utilization because patients often visit primary or secondary care repeatedly. Medication doesn't always work, and they often have associated comorbidity such as psychopathology or other chronic pain syndromes. So as Gareth said, when COVID hit, our practice in gastroenterology changed quite dramatically, almost overnight. And we had to stop doing endoscopy unless it was for an emergency. So patients who had previous endoscopies and who had a functional flavor to their symptoms, they were rejected. And patients, so new and follow-up patients with functional disorders or functional sounding disorders were rejected or were discharged with information sheets, which myself and my colleagues had created, particularly for COVID. And again, we had to re-triage all the referrals we were getting. And again, when they had a functional flavor and we thought the patients could wait and would come to no harm, we would reject them with advice where possible. And we're using a lot more advice and guidance, as we've alluded to. But looking forward, our practice is going to continue to be different for the foreseeable future because our resources are quite limited at the moment, and we're dealing with a huge backlog of patients, particularly those who need endoscopies. So this talk is really to think about how we can support you in looking after patients with functional GI disorders and giving them the best outcome possible. And the bottom line is that the shorter the duration of time between symptoms and a diagnosis or management plan in patients with functional GI disorders, the better the outcome. So that equates to keeping them in primary care for as long as possible and doing as much of the management there. So the delays are introduced when they come to secondary care. They wait for their investigations. They can be weeks or months. They then wait to be seen in clinic. Sometimes other tests are organized. They're seen by a variety of different either registrars or consultants, and their journey can take a long time, during which time the problem doesn't go away. It just intensifies because they often think that we don't really know what's going on. So having done this for a while, I think the best thing we can do for these patients is to give them a diagnosis of a functional disorder where possible, when it's appropriate, and then do as much of the management in primary care. But I think it's really important that we work together on this. And so I've thought of a variety of things that we can do and ways in which we can work together to try and maybe change that balance for that small subgroup of patients who you do end up referring to secondary care. And I'm very, very well aware that, we don't see the majority of functional patients that you see because you keep them in primary care for, indefinitely for some, and for some of them you only refer them when they're quite difficult to manage in primary care. So the first way I think that we can help support you is through development of pathways for functional symptoms. And in fact, I've been working on a pathway for gastric, so a term unique to Tower Hamlets. So functional dyspepsia or dyspepsia. So myself and Dr. Tamsangwan have been working on a pathway for functional dyspepsia. And I'm going to show you this in a minute. And the idea behind this is to standardize the management and investigation of patients with dyspepsia. So there's a huge variety in what's being done, either in primary care or equally in secondary care. So the point at which patients are referred to the Royal London for dyspeptic symptoms varies from very early on without an H. pylori test to very late, where clearly there's been a huge attempt to manage them in primary care, but their symptoms are quite resistant, and GPs need more help with managing very difficult symptoms. And equally on the secondary care side, there's again a variety of practice in when we accept the referrals. So some consultants who validate these referrals have a low threshold to accept them for an endoscopy, and others may be more confident in making that diagnosis of functional disorder early on before needing an endoscopy, and then returning them or just giving advice to GPs. So as I said, we've been developing one for functional dyspepsia, and the idea is to do the same thing for IBS and reflux, so that whether the patients are in primary care or in secondary care, they get very, very similar management. And again, like I said, I will show you the pathway. The other thing we've been doing a lot more is advice and guidance, and I think this is very well suited to functional disorders, where GPs just need a bit more advice on what to do with a patient with difficult symptoms, or where to turn to, or what information to give them. And advice and guidance is better for the patients. So if they're referred to a clinic, it takes them about 2 to 3 months to be seen, but with advice and guidance, you can get advice back to the patient in 2 to 5 days. So again, it shortens that journey between their symptoms and a management plan. I've put here webinars and education. So I give a lot of talks on functional disorders. And again, I think if it's helpful, then I'm really, really happy to give some webinars on the latest evidence in functional disorders, or management plans, or tips and tricks on how to communicate with these patients and to get buy-in, to accept the diagnosis, or even maybe to engage with psychological therapy. And I'm sure that some of my colleagues, such as Peter Byrne, who's one of our GI psychiatrists, would also be equally interested in sharing his experiences and his tips in managing these patients, with the hope that that will enable you to manage them for longer in primary care, and to give you the confidence to do that as well. The next thing I put down there is the education of patients. So the approach to functional disorders is biopsychosocial. And GPs are much better at doing that than we are in secondary care. But I like to think of it as biopsychosocial and education. And for me, educating the patients is the mainstay of what I do in these clinics. And that's much easier for me to say when I have much longer time with the patients in clinics, and much more difficult if you've got 6 to 7 minutes with them. It's very difficult to impart all that information to them in one session. And one way around this is to use information sheets, because patients can read this in their leisure. They can go back, to it. It's a much better source of information than them trawling the internet, so questionable websites, or even worse than that, forums, which a lot of them do. So I've been working on creating a lot of information sheets for functional GI disorders. They still require the rubber stamp of approval from Bart's Health to formalize them, but I would love that. I'd love to share these with you when they are formalized, so that we are using the same information sheets for patients, again, whether they are in primary or secondary care, so they get consistent advice regardless of where they are. The one caveat to this is that there is a big subgroup of our patients in whom English isn't their first language. So ideally, we would translate these information sheets to the relevant languages, and Sility comes to mind as the most obvious one. And again, if anyone is interested in working on this with me, I would be really happy to work together on this. And then lastly, I've written here direct access to allied healthcare professionals. So by this, I'm really referring to dietitians and psychologists. So most patients with functional disorders will have some dietary trigger to their symptoms, be it dyspeptic symptoms, reflux, or bowel symptoms. And in some cases, this is very easy to manage with a bit of advice, asking them to exclude gluten or dairy. or maybe, spicy foods or citrus foods. But in some cases, it's a bit more tricky, and they can be referred to dietetic clinics for the low FODMAP diet. And I know that you can access the dietetic services here. Sometimes the wait for that is long, and sometimes, and again, with the dietitians here, they do the low FODMAP clinics, but outside of that, they don't really give bespoke advice for patients with functional GI disorders. And unbelievable as it may seem, we actually do not have a dietitian as part of our neurogastro service. So again, I think if this is something that is thought to be helpful, and if you think that it might be helpful moving forward, that GPs can have direct access to a dietitian who is part of a neurogastro team, then maybe, looking forward, we can think of building a case for that. And equally, the same goes for a psychologist. So at the moment, there is a subgroup of patients who have overlapping psychology, and in whom the treatment of the functional GI disorder involves addressing that underlying psychopathology, be that anxiety, depression, or something else. And most of the time, we ask them to access or self-refer to the local IAPT service. But sometimes the wait is very long, and in a select group of patients, they're deemed too complex for the IAPT service, in which case they have nowhere to turn. And we've had experience of this where patients are not accepted by an IAPT service, but they have nowhere else to go. And again, we don't have a psychologist as part of our service. We have a psychiatrist who doesn't really have enough time to do regular psychotherapy. So again, I think if it's thought that this might be a helpful thing in managing functional patients and keeping them in primary care, then I think this is something we can discuss looking into the future. And again, I'd be very happy to work together on developing a business case for this if this is thought to be helpful. So last thing I want to do is just show you just the outline of this dyspepsia pathway that I've been creating with Roberto Tamsanguin. It's still in its draft stage, and I know it looks really, really busy, but I just wanted to show you the general outline, because we're going to use a similar outline for IBS and reflux. And I'm going to talk you through the different sections of it. If you think there is something there that is just, not right, or, that there are problems with this, then please email me so that we can make these, either email myself or Roberto, so we can make these changes before it's finalized, and that we can also incorporate those changes into the other pathways that we're going to create. So the first part just defines dyspepsia. And I know this may seem really basic, but when I see these patients with dyspepsia, often there is, I think, sometimes misunderstanding about what dyspepsia is. Dyspepsia is really more the gastric symptoms, and reflux is really not part of that. Reflux can overlap with dyspepsia, but the management of the two things was quite different. So that's why I've just put the definition there. And then it goes down to the history and the things that maybe would be good to pick out in the history, because these are the kinds of things that we would be interested in if you were to refer them to secondary care. And then this massive red box on the side, which points out the red flags, and anyone who fulfills these would automatically get a 2-week wait referral. The next section of it, the middle section of the pathway, are just pointers to all those things that you can do in primary care relating to lifestyle, behavioral treatments, education. So all very useful things. And my experience, even secondary or even tertiary care patients, is most of the time with these functional patients, it's the lifestyle factors which are a problem. They don't sleep very well, or they don't exercise enough, they eat the wrong things, etc. So just making those changes often corrects a lot of their symptoms or improves a lot of their symptoms. And then the investigations, which are useful to do. And then the final part of the pathway stratifies the patients based on previous endoscopy findings, if they have had an endoscopy, and also their response to PPI. And it directs you to where you should refer them. So either straight to test, so directly for a gastroscopy, or to advice and guidance for further management. And remember, all those who fulfilled the 2-week wait would have been directed to the 2-week wait pathway early on. So like I said, we're still finalizing this, but if there's anything, you have access to these slides. So if there's anything on there that you're really unhappy with, please feel free to email us. So Yeah, just looking into the future, I think COVID has changed the way we practice a lot of medicine, but I think it's also a great opportunity to stop and think about how we can improve our services. And, you know, for functional services, I think this is a great time to think about better collaborative working between primary and secondary care, working together on these functional patients, and thinking of how we can improve their outcomes through all those things that I've talked about. And like I said, very, very happy to work together with anyone who is interested to help develop some of those things that I've talked about. So if there are any questions, I'm very happy to answer them now.
Great. Yeah, there's quite a few coming through on the link actually. Jens, do you want to unmute yourself and ask the incident of IBS question?
Yeah, I mean, IBS seems to be increasingly more common, definitely over the last 20 or 30 years. And I wonder whether there are theories other than, so that is it a stress response? Is that one of the many ways in which humans respond to stress? Is that what has changed? Is it something to do with increasing wealth and poor diet?
Yeah.
What are the factors, do you think?
So all those things that you talked about. So stress is really important in the development of, you know, GI symptoms in general and functional GI symptoms as well. And we are all subjected to chronic stress on a daily basis, but there, you know, a lot of us cannot, you know, almost try and block that off in our head because we have to get on with our job and our childcare, et cetera, et cetera. So there is a term that we use in neurogastro to relate to patients who don't feel stress in their brain, but where the stress is kind of felt in the gut, and that's alexithymia. So it's a really nice term. But so there is a group of patients who do not feel that they are stressed, but clearly there is stress there. You know, you can see that when you see them in clinic, their knuckles are white because they're clenching their arms, they're shouting, they've got pressured speech. And those symptoms, so that stress is transmitted via the hypothalamic pituitary axis or the autonomic nervous system to their gut, where it causes a lot of GI symptoms. So stress is definitely there. And the other thing is lifestyle factors. So our lifestyle is changing. We have busy lives where, you know, we work shifts. We don't sleep when the sun goes down. We have weird sleeping patterns. We have weird eating patterns. We maybe eat more processed food, have more takeaways. So, and maybe we don't exercise enough. We have desk jobs. So all that contributes, again, to GI symptoms and to functional GI symptoms. So it's a variety of things which does it.
Okay, thanks for that. There's a whole load of questions. I'm conscious that we've got 15 minutes technically left, and we've still got Sean to tell us all about endoscopy. But I'm going to deal with these fairly rapidly, if I may. I think there's been a little bit of discussion about psychological therapy and dietetics. I think it's always very difficult for us in primary care when we get a message through from secondary care. Please refer to dietitian. I think we have as much contact with dietitians in the community as probably you do. Unfortunately, we don't really have the access for that, and it's clearly needed. Psychology support, again, the too complicated for IAPT rings very true. I'm not sure how we can get around that apart from having a psychologist in your department, perhaps. There's some specific questions about Julia, do you want to unmute yourself and ask the question about food intolerance?
Yeah, thank you. I think increasingly seeing people with concerns about food intolerance, and it's really difficult to unpick. And I suppose I lack confidence when people describe sensitivities to food. And so just kind of wanting thoughts about that, really, because some people will then eliminate large food groups from their diet, which is a particular concern if there is no sort of dietitian support or nutritionist support for them. So thoughts would be really helpful.
So all these are really relevant questions. I could speak for a long time on all of these questions. So food intolerance, increasingly common. and some of it is true intolerance, and there are patients who are lactose intolerant, and some patients have carbohydrate intolerances. So, but that's a small proportion of them. And then there are those with gluten intolerance where they get some symptoms, and it's not such a big deal if they only cut out gluten. But yes, what you describe, when there are patients who have intolerances to almost everything, and that is not really an intolerance, that is a restrictive eating disorder in a lot of the cases. So because they have functional symptoms and because they have hypervigilance, they're very aware of their symptoms. They get a symptom with food that any of us may discount and say, well, I've just eaten a big meal, so I feel a bit bloated or I have a bit of reflux. But they will interpret that as an intolerance to that food. So they will cut that food out, which will lead to more intolerances. But then they do this with subsequent foods, and they end up on a very, very limited diet with, nutritional deficiencies and potentially weight loss as well. And a lot of these patients do end up in my more tertiary clinic. And what I try and do is to broaden their diet out. So I'm very happy for them to cut out one food group like gluten or dairy if that helps their symptoms. But if it doesn't, they need to go back onto that. But ultimately, I think the aim is really to broaden their diets out. And I think if they've got this phobia about particular foods, again, they need psychological therapies for that, which is why, I talked about, maybe access to psychology. But yeah, it's a difficult problem, and we have more time to deal with it in secondary care and to, unpick the reasons why they might have those intolerances or perceived intolerances.
Okay, Julia, there was a second question there. Do you want to just pop that in?
Thank you. It was just a kind of an awareness that with our population having large numbers of people with diabetes, that some of them may have delayed gastric emptying, but it's hard to know what proportion is that and whether there's something more we should be doing. So sometimes that prompts me to think about referral because of the uncertainty about whether it's functional or that.
So yeah, another great question. So there is gastroparesis or delayed gastric emptying in diabetics. But, there's a very poor correlation between the degree of delay in their gastric emptying and their symptoms. So historically, when that term gastroparesis was coined, they talked about delays of 24 hours in gastric emptying. Whereas now when we do the test, we see a delay of 10 minutes and we say, oh, they have delayed gastric emptying. And then we use the medical term gastroparesis, and they're labeled as a gastroparetic, if you like. But the majority of these patients with diabetes and GIs or like nausea and dyspepsia actually have functional dyspepsia. And so I deal with a lot of young people who are type 1 diabetics with vomiting, and they have delays in their gastric emptying, but prokinetics don't work, but psychological therapy does, which suggests that it's not the delay in the gastric emptying that's a problem, but it's more the psychology. But I think if it's someone who's vomiting on a daily basis, regurgitating food, losing weight, having a lot of reflux symptoms, they warrant an OGD and potentially a gastric emptying test, but they definitely warrant a referral to secondary care gastroenterology. Yeah.
Okay, thanks for that. I'm conscious I'm going to take two more previous questions, and I'm going to ask you maybe just to have a look at the other questions in the chat and answer them as Sean is presenting, if that's okay. The one question from Sangeeta. Sangeeta, do you want to unmute yourself and ask your question? I'm ashamedly, I don't know what your acronym is, so I probably should. But could you ask your question then?
Okay, thanks, Phil. Yeah, so we've had increasing number of patients asking treatment for SIBO. I don't know how you pronounce it. It's small intestine bacterial overgrowth, and they get this tested sort of privately. They're usually patients who have like quite challenging IBS-like symptoms and bloating, and so and then they want treatment for this SIBO, which is
So again, very big problem for us, and I'm sure even more so for you, where patients are going to the private sector, getting the test, saying that they have bacterial overgrowth and demanding antibiotics for this. So the evidence for bacterial overgrowth is very poor. The pathways aren't very well outlined, and we've had discussions about this at our consultant meetings here. So a lot of people, so the tests aren't very reliable. So there are lots of false positives, and even when they are positive and you treat them with antibiotics, a lot of them either respond while they're on antibiotics and then their symptoms recur straight after the antibiotics, or they don't respond at all. There is some very, there is a bit of evidence out there for rifaximin in these patients, but I'm aware it's very expensive. And if patients respond to that, and if it's a placebo effect, they want it again. So it's a big problem, and I think you're right. We need to create some pathways for that. So maybe that's one of the next things on my to-do lists, is to create a pathway for SIBO. But I think if they've had the test done privately and they're demanding antibiotics, again, you can just go through advice and guidance, and I can try and pick that up and see what we would advise. But generally, you can ask them to take a course of probiotics if they're really keen on that, and see whether their symptoms get better. But most of them just have severe IBS, or they have severe functional abdominal symptoms, and they don't really have underlying SIBO.
Okay, that's great. Yeah, I have resisted prescribing antibiotics and usually kind of referred them to you guys. So
the big exception are patients with severe connective tissue disorders or GI neuromuscular disorders. So patients with pseudo obstruction or scleroderma, where they might have true SIBO. But other than that, a healthy patient who's got a bit of bloating and IBS type symptoms, I don't think they really warrant antibiotics.
Dr. Thickery.
Okay, thank you very much for that. I'm going to draw that to a close now. And Gareth and Asma, could you answer the question about the specific question about probiotics, and Alex Pinder's question about bloating in the chat, whilst we pass over to Sean to talk about endoscopy, because I think that's for many of us, referring for endoscopy and the access that we have to it is a really important topic that I don't want to lose. So if I can pass over to Sean now and leave it, and thank you very much, Asma. That's a very interesting presentation, and leave you and Gareth to answer those questions as we go forward.
Lovely. Thank you very much, and thank you for all your attention. I realise it's well into a very sunny Wednesday evening. Asma, are you still sharing your screen, or is that gone?
That's gone.
Okay, lovely. Let me just try and get that back. Wonderful. Can you see my screen now or not?
We can now, yes.
You can. Lovely. So really, a lot of this ground has been covered by others. But what I want to talk to you about is really about our COVID story, but most importantly, how we can serve you and your patients now. But setting the scene a little, as Gareth and Esma did, it was all hands to the pump 12 weeks ago. And we were doing emergency endoscopy only. And really that meant, in terms of upper gastrointestinal procedures, we were doing gastroscopies for almost complete dysphagia for nothing else. We were doing colonoscopies for patients who were obstructed. We were putting stents in their obstructed cancers. And we're doing ERCPs in those patients who had infected obstructed bile ducts. We know all outpatients were cancelled, and there was little in the way of imaging other than the very urgent CTs and MRs, and no GI physiology. But important to tell you all, as of Monday, we are now up and running with GI physiology with Daniel Zifrim and his team. So we contacted the patients at that time. We explained that their procedures were being cancelled, and some of them they were wary at this stage, not really fully understanding that onslaught, that tidal wave that is about to hit us. As Gareth said, I was involved in setting up the GI unit at the Nightingale. There's Darius, one of my colleagues, with our emergency endoscopy stack. There's the sign language we all learned to do these endoscopies in the difficult, noisy, challenging environment. Thankfully, we didn't need to do one. Of the 50 patients admitted, none had an acute GI bleed, either up or lower. So our endoscopy stack has now been brought to Royal London and used for our inpatients there. So at least there's been some benefit. And of course, a very good insurance policy for us all to have. This is a slide really telling us how our services, as Gareth did, were dissolved during this time and taken away from our clinics and taken away from our endoscopy unit. But you know better than I the huge problem that is out there, the waiting lists that are growing, and equally as concerning, those patients of ours with symptoms that are sitting at home with their rectal bleeding, with their weight loss, their abdominal pain, that are too frightened to come and see you, and are certainly too frightened to come and see us. So what I'd like to do in the next few minutes is try and work out a way which we can reassure our patients and make sure they come to see us in as efficient way as possible. Here's a slide from Ed Seward's frontline gastroenterology paper, just showing the normal process map for a colonoscopy. You know a lot of that. There's a lot of waste in there. There's a lot of waste at your end. There's a lot of waste at our end. So we do need to be thinking about how we can do things differently. And some of the lessons we've learned during the COVID times have taught us how we can do things better going forward, and we'll talk a little bit about that. In terms of the upper GI tract, dysphagia is what it's all about. Those are the patients I'd like you to be concentrating on now, particularly those with progressive dysphagia to solids. They're concerning. And in the next slide, I'll show you the Edinburgh score that can help discriminate between the benign and malignant causes of dysphagia, so we can, as this talk is all about, get the right patients to the endoscopy room at the front of the queue. Obviously, we're concerned about our patients, particularly over the 55 and weight loss with dyspepsia. Vomiting is only very rarely a functional symptom, so has to be explained really with a gastroscopy if there's no other obvious explanation. And all our patients, but particularly our male and postmenopausal female patients with an iron deficiency anemia, so not iron deficiency on its own, that can be explained, that should be investigated only with a celiac serology, but patients with a low ferritin and a low hemoglobin, we should be doing a gastroscopy and celiac serology in all of those. And of course, the patients with abdominal mass. Test and treat, there's really good benefit for that in our younger patients with symptoms. That's testing for Helicobacter. We'd usually do that with a stool test. And remember to make sure your patients have been off any proton pump inhibitor for 2 weeks before they're tested to rule out false negatives. And it's once they are found to be positive, treat them accordingly, and very few need repeat Helicobacter stool antigen to confirm that positivity. If you've given them treatment, you can expect in 80% of the time that Helicobacter will have been successfully eradicated. So here's the Edinburgh Dysphagia score that I was talking about, published recently by the BSG. They looked at the Edinburgh group, about 400 patients, and you can see you can get various scores depending on the age of the patient, where their dysphagia localizes to, the duration, the gender, whether they've got acid reflux and weight loss. And you get various positives and negatives on various things on how that's weighted. And if your score is greater than 3.5, your risk of cancer is reasonably high, and then you would warrant an endoscopy. In that paper that they looked at of those 400 patients, only 1 of 20 had a high score of lower than 3.5 and had cancer. So really a very good scoring system. So I'd encourage you to use that. Where we can make a big difference, and we talked about fit testing in some of the questions earlier on, it's really important adjuvant to other symptoms consistent with a colorectal cancer. Change in bowel habit is important, but particularly a sustained looser, more frequent stool in a patient over 50. And one symptom that I find is very discriminatory in terms of positive hard pathology rather than functional pathology would be nocturnal symptoms. If a patient is having to get out of bed at night to open their bowels, I'm going to take that diagnosis really seriously and make sure I exclude either inflammatory bowel disease or a cancer until I start entertaining various other diagnoses. Abdominal pain, very common, but can be a sign of abdominal or colorectal cancer. We know about weight loss, iron deficiency anemia, rectal bleeding, and of course that abdominal mass that we only very rarely see, but I'm concerned we may see in the future, given that our patients are sitting on their other symptoms I mentioned longer and longer. Gareth talked very briefly about fecal calprotectin. That's really important in our younger patients to discriminate between irritable bowel syndrome, Esma's presentation, IBS and IBD, inflammatory bowel disease that Gareth talked about. So when we look at that, the IBD in the younger patients compared to IBS, that's a very good sensitivity, particularly when that level gets to greater than 150. So I'd use that, but obviously the higher it is, the more important it is to do that. So in a young patient with a low fecal calprotectin, that is very unlikely that patient has inflammatory bowel disease. There are, of course, false positives or other causes of a raised fecal calprotectin, such as acute infection, cancer can do it, diverticulitis, a microscopic colitis, celiac disease, and of course, non-steroidal anti-inflammatory drugs that can cause most gastrointestinal symptoms. The FIT test, I think, is really very helpful. It is not a perfect test, and we really have to remember that. But in answer to one of your questions earlier, it is really how we are taking our patients now referred to our hospital on the lower GI pathway. All patients will have a FIT test, and what we've done, and I'm Director of Endoscopy across Barts Health, we've now cleared all those patients with a FIT fecal immunohistochemical test of greater than 150, and then we are now working from those between 100 and 50, and then we're working backwards, as well as those with a significant iron deficiency anemia. So it's another tool to use to identify those of our patients with highest risks of significant pathology. This is much better than the FOBT, the guaiac test, which we no longer use. It's human hemoglobin we're picking up with this test. It's one sample, it's far more reproducible than the FOBT, and there's no dietary restrictions. Mike McChesney, who I'm sure you all know, has got a really excellent paper soon to be published, but he's happy for me to share, where they looked at 4,500 FIT tests in patients referred on the urgent 2-week way pathway in 2017 to 19, and recruited just under 4,000 patients. And what they identified was with a FIT of 150, they were picking up the majority of the cancers, but we have to remember that that was still, of the cancers found, which were 90 out of that 3,500 patients, still 1 in 6 of those with a FIT of less than 10 had a colon cancer. So it is not a perfect test. It is better if you look at it in the context of anemia and abdominal pain, where you've got a 1 in 16 chance of having a cancer if your FIT is less than 10. But please do use it, and please use it with your patients. Include that in your referral to the 2-week break pathway, because if it is high, if it is greater than 10, it will get your patients above those referred without a FIT, or those with a FIT less than 10. So this is what endoscopy looks like in the post-COVID world. It's something I would have done for fun in early 2020. It is hard work now, particularly when you put a lead coat on top of that and a full FFP3 mask. It is very difficult, but we're protecting your patients, our patients, and our staff by screening all the patients before they come to our unit. We are now, the first cohort of swabbed patients came through today. So as of next week, all our patients will be self-testing at home for PCR COVID swabbing. And then asked to self-isolate for 7 days pre-procedure. We will be, by that time, a fully green unit, meaning that our inpatients will be performed or are being performed elsewhere, and we will only be seeing COVID negative patients in our unit. As many of you know, we have 5 rooms. We're normally working 6 days a week, morning and afternoon. We're currently running 3 within the department, 1 outside, and 5 days a week. I'm sure it soon will be 6 days a week, but our efficiency is about 40% of what it was. So those patients on the waiting list will be waiting longer, but it's really important that both you and we protocol those effectively. We've been doing other things. This is Gareth and myself and Yanis Kallis, who some of you may know, up in Coventry, engineering a new type of hood to go over patients while they have a gastroscopy. That reduces the waiting time for aerosols to fall between procedures, and we're waiting for our next version of this model, and we hope that will increase the number of patients we'll be able to see per lists. So we talked a bit about
questions. Couple of
Yeah,
questions
please.
coming in, just if we could take them. Alex is asking if the patient has known PR bleeding, is there any point in doing the FIT test?
I still think it is. It does sound unusual, but one of the things it does, it gets them up the list.
Okay.
So
Okay, that's fine. That's a good answer.
Intuitive.
So don't stop referring, but don't wait for the FIT test. But when the FIT test is back, if you feel it's urgent, add it in. Yeah.
Absolutely.
So, and Nirupam, who's responsible to organise the FIT test? My understanding, and I think Gareth has made it in the comments as well, the only way of getting a fit test is through primary care at present. It's not available to you in the hospital world. Is that right?
Yeah, that if you guys can do it, that is much appreciated. Some have been instigated on the patients that were referred without it. That backlog, we believe, is now cleared. So if you could refer with the fit test, that is how the system has been designed.
Okay.
And I might just jump in that even for the upper GI pathway, if you think the patient, so for example, iron deficiency anemia, or they've lost lots of weight, those are patients who traditionally we would have been doing a colonoscopy in, and we're not now. And so some patients have been really delayed because we haven't got a fit test, and then we're struggling to get access to one.
Okay, so that's pretty clear. Thanks for doing that. I mean, it's not a particular popular test with the patients, but it's one that clearly is needed and is a route to prioritizing those people who desperately to see quicker. Yeah. Okay. Sorry to cut you off there, Sean. Was there anything else that you wanted to say?
No, that was a very rapid trot through. I've got the point really is we're there, we're scoping, they're sufficiently before. So if you can triage our patients from the time of referral, that would help everybody.
Yeah, thanks. There's a question coming in on the so upper and lower GI referrals need Gareth. I think what Emma means is that do they need a fit test rather than?
So I'm just making a specific. Oh, sorry, Sean. You go.
Carry on, Sparky.
So it's all lower referrals, definitely. Dysphagia, dyspepsia, vomiting, you probably don't need it. But if you've got those kind of nebulous weight loss, I really don't know what's going on, and you're referring them through on that pathway, if you've got somebody with iron deficiency anemia, anyone in which you think the algorithm might well be that you're going to need a colonoscopy, please add it in. Or if we contact you or one of our team members contacts you to do it, please don't be so cross. And this is not us using you as house officers, as I've seen in some of the feeds. We promise we simply can't do it.
Okay, I think that's very clear. Right. I think that's probably, we've overrun, and I'm really sorry for that. It's my fault for not chairing more efficiently. So very many apologies, but very many thanks to Sean and Gareth and Asma for taking time tonight, and thank you very much to everyone who's attended. I think we hit over 40, which is slightly more than I was thinking in this current weather. So that's great. Just shows the importance of the topic, and I think also we've had more questions tonight than we have had in the last 6 or 7 webinars combined. So clearly a subject that is close to everyone's heart, and we need to make sure that we've got the FAQs done. So great, thank you everyone. Good night, and if those of us who've been part of the talk can stay on afterwards, whenever else logs off, we can debrief a little bit.
Okay.
But thank you very much, and good night.
Yeah, no, I'm on. I'm actually